this program. Good afternoon and welcome this afternoon to the Mirowitz Center program with Dr. Bendich, hip replacement. And so Dr. Bendich is currently an assistant professor at Washington University School of Medicine in the Department of Orthopedic Surgery. He utilizes evidence-based, cutting-edge techniques and including computer assistance and robotic technologies for improved surgical outcomes. Please welcome Dr. Bendich.
Thank you, Judy. I appreciate it. So I'm going to go ahead and share my screen. If there are any issues seeing it, please let me know. All right. Judy, can everybody see my screen?
Yes, I believe everybody can. Yes.
All righty. So thank you, everybody, for your time. It's a privilege to present to you. I get really excited about hip arthritis and hip replacements. My specialty and my practice is exclusively in joint replacement. And that's lower extremity joint replacement in hip and knee replacement. So this is what we'll go through today. First, I'm just going to introduce you to myself so that you understand who it is that's presenting to you. Then we'll talk about hip arthritis. We'll talk about the various options for treatment. That includes non-surgical treatment as well as surgical treatment, which is a hip replacement. And then I'll tell you about some recent innovations in the world of joint replacement. So first about me. So I've been all over the place. I was born in Uzbekistan, which as you can see on the top right, that's a map of where Uzbekistan is. But I was raised in New York, and that included Queens and Flushing, New York, as well as various parts of Long Island. And then my first foray to the Midwest was in college, where I was fortunate enough to attend Northwestern University. And that's where I met my wife as well. Then I went back to the East Coast and did a combined business and medical school degree. And that was at Dartmouth College, which is one of the smaller Ivy League institutions. Then I was fortunate enough to attend residency in San Francisco at UCSF, which is one of the premier hospitals and definitely a premier orthopedic surgery program. And most recently did my fellowship in hip and knee replacement at the Hospital for Special Surgery in New York City. And that's the highest volume orthopedic hospital in the world. So my practice is at Washington University, and I'm very, very fortunate to have the opportunity to learn from and to work among world-class faculty and staff. And I believe two of my team members will be joining on this call today, my nurse and my MA, and that's Katie and Linda. So my practice is focused on hip and knee replacements. And I do both primary joint replacements, meaning those that are simpler cases, as well as complex and revision joint replacements or redo joint replacements. And my specific focus is in using technology to improve outcomes in joint replacement. So every primary knee that I do, every primary hip that I do, and many revisions that I do involve either some form of computer navigation or robotics. So I'd be remiss to introduce myself if I didn't talk about my family. So my family is my backbone. They support me. That includes my wife, Sarah, and our son, Mason. And as you can see in the picture on the top right, this is one of many pictures I have of my son Mason on some truck, as that is his current obsession. So enough about me, let's talk about why you're here, which is to learn more about hips and specifically hip arthritis. And the focus here will be osteoarthritis. And that's a distinction from some other arthritides that you may have heard of, like rheumatoid arthritis, psoriatic arthritis, etc. Osteoarthritis is a wear and tear problem, whereas the other ones I mentioned are inflammatory arthritides. So the picture that you see on your left is what a normal hip looks like. The hip is composed of, it's a joint that's composed of the femur or the femoral head and the acetabular socket. And it's enclosed by a joint capsule, which is this white grayish material that you see in this diagram. And the femoral head, as well as the acetabular socket, have cartilage surrounding them, and that allows for gliding of the joint, which allows for essentially pain-free range of motion. Over time, as we age, and as the wear and tear sets in on our hip, that cartilage gets damaged. And so we eventually progressed to this process that we see on the right, and that's the osteoarthritic hip, where the cartilage wears away, it gets destroyed. Our body responds by an inflammatory process which can incite bone spurs. And what this amounts to is narrow joint space. What you as a patient or what one patient may experience is a decrease in range of motion, stiffness, and pain. And in a later slide, I'll show you where that pain tends to manifest. But the idea here is this is a disease process that's largely wear and tear, and it's different than a non-osteoarthritic hip, which may be due to inflammation or an autoimmune response. So who does osteoarthritis affect? About 5% of the population has arthritis that's both present on x-rays as well as causes symptoms. And each individual has about a 25% lifetime risk of developing arthritis at some point. And again, wear and tear problems. So the longer you live, the more likely it is that you will develop arthritis. There are a number of risk factors that can predispose one to arthritis. Genetics is one. So if you come from a family where various members have had joint replacements or have had arthritis, odds are you may go on to arthritis as well. Heavier weight is also a potential risk factor. If you think about the cartilage surface as the tread on your tire, the heavier your car, the faster that tread's going to wear. So it's the same idea. If you think of the cartilage as that, the heavier you are, the faster or the quicker that cartilage is going to wear over time. Additionally, injury to the hip joints can predispose one to arthritis. So this can be either a fracture that's within the joint capsule. It can be an injury to the cartilage surface itself, or it could be an injury to the labrum. And so there are a variety of ways to potentially injure the hip joint that could then later on lead to an arthritic process. Additionally, some people are born with something called hip dysplasia, where the acetabular socket may be malformed, and this may not be caught in childhood. This may then go on later in life to develop into an arthritic process secondary to a dysplasia. There are other deformities as well that can be either someone can be born with, or they can be acquired in childhood that can predispose one to an arthritic process. And then if you were really active in your childhood with high impact sports, and this could be a football or a lot of running or a lot of sports, that also creates a lot of wear and tear on that cartilage surface, leading to that arthritic process. And then, as I mentioned earlier, the longer you've been on this earth, the more wear and tear your cartilage has seen. And so the higher the likelihood that you go on to an arthritis. So how does arthritis present? If you look at the diagram on the right, this is from a study that was done where the researchers surveyed patients who had radiographic arthritis and who had symptoms, and they asked them to draw on a diagram where their pain mainly was. And this is for hip arthritis in particular. The darker the red, the more consensus among the answers. The lighter the red, the less consensus. So what you can see is patients really have pain in their groin and some on the outside of their hip. And what I really find people saying is it's either the groin or they make the C shape with their hand that cups around their hip joint. The pain can also radiate to the buttock or to the knee, but arthritic pain never goes beyond the knee. If you're having pain that's going beyond the knee, that is concerning for a different etiology, potentially pain that is emanating from the spine. Additionally, patients, as I mentioned earlier, would have stiffness or decrease in range of motion. And the first aspect of range of motion that's lost is internal rotation, where you try to get your foot outwards. And then the osteoarthritic hip also tends to have pain that's worse with increasing activity. So patients really complain of pain that's worse at the end of the day. If you have an inflammatory arthritis, like a rheumatoid arthritis or psoriatic arthritis, the pain tends to get better with activity. So that's another way to potentially differentiate the etiologies. So how do we diagnose arthritis? In my clinic, it's based on history, exam, as well as imaging. So in the history, it's somebody telling me where their pain is and characterizing that pain. So if somebody says I have a pain that feels kind of like a toothache, it's dull, it's achy, it's sharp with certain motions, I think of an arthritic process. But if someone says I have a burning or electrical pain and it may or may not go beyond my knee, then I start thinking it's actually the spine that's the problem, not the hip. And then once I hear the story, I try to elicit their complaints on exam. So we check range of motion, we do provocative tests to see if certain motions of the hip do cause pain in that groin. And we look for other factors, like, is it actually a bursitis that's causing the pain, not an arthritis? A bursitis is inflammation of a fluid-filled sac on the outside of the hip. And then I also look and see, is it actually the spine that's causing the problem? So we do provocative tests to evaluate the spine as well. And then lastly, after I've spoken with somebody, examined them, we get an X-ray to see if the story makes sense and correlates with what we see on the images. So what you see on your right, actually, let's start with the image on the left. What you see in the image on the left is a normal hip. So you see the femoral head articulating with the acetabular socket, and what you see is space between the femoral head and that socket. That space is filled with soft tissue that the X-ray just doesn't pick up, but we know it's there because there's a space there. And that soft tissue that I'm talking about in particular is cartilage. So the more space, the better. What you see on the right is an osteoarthritic hip. And as you can see, there's no space between the acetabulum and the femoral head. This is bone-on-bone arthritis. You see the formation of periarticular cysts, and you also see sclerosis or whitening on the X-ray. This is a very unhappy hip that tends to hurt quite a bit. So that is how we make the diagnosis. So now we've talked about hip arthritis, let's talk about some of the treatment options. So there are non-surgical treatment options, and in my practice, I really try to exhaust every non-surgical treatment option before we get to surgery. So some non-surgical treatment options include activity modification, which means if something hurts, don't do it. That's obviously not possible for a lot of people because the things that hurt are sitting in a car, going up and down stairs, and just walking. And those are activities of daily living that people need to be able to do. So activity modification is not something that I stress much. If somebody is overweight, we do discuss weight loss, and we have clinics that we can send patients to that can assist with that process. Then we get into medication discussions, and specifically the medications that tend to help are non-steroidal anti-inflammatory drugs, or NSAIDs. Those are the Advils, the meloxicams, the Celebrexes, the Aleve, that category of medication. And the idea behind that medication is, again, arthritis causes inflammation or swelling in the hip, and these medications take away that inflammation and that swelling. So if we can decrease that, we can help control pain for patients. It doesn't reverse the process, it doesn't bring the cartilage back, but the idea is to control the pain. Additionally, we recommend physical therapy. So physical therapy works on strengthening the muscles around the hip to offload the hip joint. In my practice, I find this tends to work better for milder arthritis, but once somebody has the arthritis that we saw in that last X-ray, physical therapy tends not to work as well. So then we go on to injections, and I use injections for two purposes. One is for diagnosis and the other is for therapeutic purposes. So if I'm uncertain where somebody's pain, if somebody's hip pain or their groin pain is coming from their hip or from their spine, one way to find out is to inject the hip. If their pain goes away after a hip injection, then I know it's the hip that was the problem. If they're still having that same pain in their hip that they had before the injection, then I know it's something else, likely the spine that's the problem. Additionally, injections do provide therapeutic relief. So patients can expect, it's frankly kind of hard to predict how much pain relief they can expect and for how long. Some people say that they get pain relief for a few days, others get it for months, and in rare instances, years. So an injection is definitely an option if somebody is trying to avoid or delay a surgery. And then lastly, for hip arthritis, once somebody has failed all the non-operative measures, such as the ones we discussed, then total hip replacement makes a lot of sense. So let's talk about total hip replacement. So what you see on the right is a diagram of, or a caricature of what a hip replacement is like. So it involves putting in implants to remove the arthritic surfaces and to restore the hip biomechanics. So starting with the acetabular component, we ream the cartilage and some of the bone out of the acetabulum and put in this cup, or the acetabular component. On the femoral side, we broach or ream the femur and put a component in that is either cemented or press fit, meaning that it gets a really good fit and bite in your bone, so that it's held in place. And then attached to that implant is a femoral neck, and then we attach a head to that femoral stem, and the heads tend to be ceramic these days. And then we add in a liner, which could either be plastic or metal, depending on the type of implant we use at the time of surgery. So that's a general idea of what we implant when we're doing a hip replacement. Surgery on average takes anywhere from 1 to 1.5 hours after we start. There is some time in terms of positioning the patient on the operating room bed, as well as closing the wound. And then, like I mentioned before, the arthritic surfaces get replaced with implants. So the pain generating aspects are gone. Patients walk right away after surgery. At our facility, our goal is to have patients walking within 2 hours of surgery. And hip replacement has been considered the operation of the century. It's considered one of the best surgeries that we humans can offer other humans. And the satisfaction rates are pretty high with hip replacement. That's not to, so let's talk quickly about the recovery, then I'll tell you about potential complications with hip replacement. So the recovery has drastically changed in the last few decades. It used to be that patients would stay in the hospital for upwards of 3 days, if not a week. Now patients are staying in the hospital anywhere from 0 to 1 night. Some patients go home the same day. I keep all my patients in the hospital for 1 night. And the only reason I do that is if something were to go wrong, it's better that it happens in the hospital than at home when you can't manage it, or it's tougher to figure out what it is that's gone wrong. So my patients stay 1 night and tend to go home the next morning. And during that, first day of surgery, as well as that day after that first night, patients work with PT and they learn their precautions and make sure that they are good to go for when they get home. Most patients are off pain medications by 3 weeks. In my practice, there are patients who are off pain medications the first week after a hip replacement, and those who need it for 3 weeks. It's pretty rare for it to continue beyond 3 weeks. Depending on the type of hip replacement that one has, there are restrictions associated with it. If I perform a posterior hip replacement, there are what we call posterior precautions, where patients can't deeply flex or internally rotate their hip, and that's to prevent a potential dislocation. If we do an anterior hip replacement, it's to prevent patients are prevented from extending their hip and rotating outwards or externally rotating. And these restrictions tend to be in place for about 6 weeks as the soft tissues kind of settle down. The restrictions, for the most part, don't limit anyone from doing anything that they want to do. And patients continue to have improvements in their pain as well as their function, and these go on for anywhere from 6 months to a year after surgery. So I think the most rapid progression is made between the day of surgery until about 2 to 3 months after surgery. Then things kind of taper down, but gains are still made until anywhere from 6 months to 1 year afterwards. So as I mentioned, every surgery has complications, as does hip replacement. So some of the potential complications include infection. Infection happens in about 1% of cases, and it's a fairly devastating complication that tends to require additional surgery or surgeries to address. The good news is 99% of patients tend not to have an infection after a hip replacement. The next complication is dislocation. This is where the ball pops out of the socket. And what I'll talk about later are steps we're taking to minimize the risk of dislocation. But this, if you look at the table on the right, which shows a study that looked at all the reasons hips are revised or redone, and dislocation is the most common reason that a hip needs to be redone. And specifically, this is recurrent dislocation. So if somebody has a one-time dislocation, they usually don't need a revision, but if they go on to dislocating more than one time, then a revision is recommended. So in my practice, this is something I really focus on and try to minimize. Additionally, another potential complication is a fracture, where we can either fracture, most commonly on the femoral side, on that thigh bone side. We can fracture during surgery, or a patient can fall or have something happen where they fracture after surgery. Additionally, the components can loosen or they can fail. So as I mentioned earlier, there are a number of ways to put in these components, one of which is called press fitting, where we really need good fit of that implant in the bone. Because if there are micro motions, the bone may not grow into or onto the implant, which is required for these to be stable. If we cement, it's different. And then there's always a risk of nerve injury with hip replacement, whether we go anterior or posterior. There are different nerves that are at risk, but there's always a nerve that's potentially at risk. The good news is these complication rates tend to be very low. So while they do exist, most patients tend to not experience one of these complications. So let me tell you about the different approaches to hip replacement. The workhorse and the most common approach is the posterior approach. So if you look at that diagram all the way on the right, it shows you where the approach is made. And it's really kind of on the outside and backside of the hip. Now, increasingly, surgeons are performing the anterior approach to hip replacement, which is an incision that's on the front and side of the hip. And each of these approaches has different pros and cons, and I do both of these and I cater them to my specific patient that I'm seeing at the time. So let's talk about potential advantages of each type of approach. So we'll start with the anterior approach. So the anterior approach, where we go from the front, the main advantage is that patients tend to have a lower dislocation rate. So a lower rate that femoral head is going to pop out of the sockets. Conversely, there are potential disadvantages. So there is a higher risk of wound complications going from the front. And this is in particular for patients who are heavier or who may have a skin fold over the front of the hip. Additionally, there are femoral complications. So the femur is not as easy to see in the anterior approach. And as a result, fracturing is a possibility. So given these advantages and disadvantages, the patients that I tend to do the anterior approach on are thinner patients who are at higher risk for a dislocation. And in my practice, patients who are high risk for dislocations are those who really want to stay active and do things that require pretty significant range of motion. And those activities include yoga, I would say horseback riding, anything that requires getting any sort of extreme of range of motion. Additionally, patients who have a concurrent spine problem, we have recently found out that the spine greatly influences dislocation risk for the hip. So anyone with a spine problem, I tend to want to go anterior to minimize the risk of dislocation. Again, that risk is not zero, but it's lower than with the alternative, which is the posterior approach. Additionally, if somebody has what looks like strong bone on the x-ray, specifically on the femoral side, I'm more likely to go anterior. If somebody has very thin and frail bone, I'm less likely to go anterior because, like I mentioned earlier, femoral complications are higher in the anterior approach. So the good thing is I do both approaches, so I can cater approaches based on the patient. So now moving on to posterior approach, the femoral access is easier. This is really a very extensile approach that allows great access to both the acetabulum and the femur. There's a lower risk of wound complications as the back of the hip tends to tolerate surgery better than the front of the hip, but there is a higher risk of dislocation. So the patient that I tend to do this on is somebody who may be either heavier or have some sort of deformity that otherwise I wouldn't feel comfortable going anteriorly. And for somebody for whom, they don't have spine problems, and I don't think their dislocation risk is going to be much higher going posterior than it would anterior. So recently I published this article which compared the two approaches, and specifically we looked at intraoperative complications as well as early return to the operating room between the two approaches. And early return to the operating room meant returning to the operating room within 1 year for any potential reason related to the initial hip replacement. And what we found in this study is comparing anterior to posterior hip replacement is that there really is not a difference in intraoperative complications, but there is a difference in early return to the operating room, with the anterior approach having a lower likelihood of going back to the operating room for a redo surgery within 1 year for dislocation in particular. So now that we've talked about hip replacement, the various approaches, what someone can expect in terms of recovery, let's talk about some innovations. So as I alluded to before, one of the key innovations really in the last 10 to 15 years is hip surgeons have realized that the spine critically impacts the hip. Specifically, deformity of the spine and stiffness of the spine, as well as instrumentation of the spine, like a prior spine fusion, greatly affects how that acetabulum moves when somebody goes from sitting to standing. And that affects what's considered the quote unquote safe zone for placing our components. So without getting too technical, what this means in my practice is I now get x-rays on everybody when they are sitting, as well as when they're standing. And those x-rays include their spine, the patient's spine, as well as their hip. And I see how the hip moves based on what their spine is doing. And for me, that helps really narrow down and hone in on how I'm going to put my components to maximize the patient's range of motion and minimize their dislocation. And this is really quite a new thing that's, like I said, been going on maybe 10, 15 years and has really kind of recently gained adoption. And what this diagram shows is patients with spine stiffness, spine deformity, and spine hardware. And you can see how it affects their pelvis and how their pelvis tilts when they're standing. So putting in a component in the same exact position for every single patient is probably not right. And these things need to be somewhat tailor-made for each patient, depending on what their spine is doing and the function of their spine. So recently I published a paper that's got accepted within the last month. And this compared doing posterior hip replacement using no technology to doing posterior hip replacement using computer navigation or robotics. And what we found in this study was that complication rates were fairly similar, regardless of whether technology was used or not, except for dislocation. Within 1 year, the dislocation risk was lowest in patients who had robotic posterior hip replacement surgery. And my assumption is that one of the reasons we found this is because robotics allows the surgeon to account for that spine and how the patient's individual anatomy, because the robot that we used requires a CT scan, which is going to show different anatomy for each patient. And it also accounts for some of those hip spine parameters that I mentioned earlier that greatly influence how the acetabulum moves and allows us to maximize range of motion for patients. And a lot of these decisions are made before we even enter the operating room. So this is a kind of example of some of the technology that I use and some of the technology that I think is going to become more prevalent as we move forward with hip replacement. So on the left is computer navigation, and this is something that I currently use for all my hip replacements. It involves a camera that looks at where the surgeon's hand is when they're reaming, and it also allows you, when they're reaming and implanting components, and also allows for measurements in terms of leg length differences, as well as restoration of biomechanics measurements. And I'm currently using this for all of my posterior hip replacements. For all my anterior hip replacements, I use X-ray that also has a navigation component to it to allow me to really hone in on leg lengths and positioning of components. What you see on the right is a robotic arm, and that is robotic hip replacement. This is something that's coming to WashU in the very near future, and I will be using this extensively for my posterior hips. And again, the advantage is we would get a CT scan of the patient's individualized anatomy. We would be able to see how their impingement or where they potentially dislocate when they're sitting, when they're standing, and we'd be able to maximize the range of motion before we even get in the operating room. And then we would be able to execute it perfectly, the surgical plan, because the robot would assist us in making sure that the components are put exactly where we plan to put them. So we talked a bit about hip arthritis. We talked about how patients present with hip arthritis, both in the clinic as well as radiographically. We talked about various treatment options, including non-operative options, total hip replacement, as well as some of the innovations going on in hip replacement. This is obviously not everything, but it's as much as I was able to include in the scope of this talk. So this is a little bit about me again. So I'm one of the surgeons at WashU. I specialize in hip and knee replacements, and my focus is on technology-assisted joint replacement, as I do think that this is making a pretty significant difference for patients and minimizing some of the complications that we've seen in the past, specifically with hip replacement. So my offices currently are in Creve Coeur at Barnes West County, as well as at Progress West in O'Fallon. And I operate at Barnes West County as well as downtown at the BJH Main Hospital. So happy to answer any questions about anything that it is that I talked about. And thanks for your attention.
Thank you so much. It was really wonderful. Let's see if anybody has a question. You can type it in the chat box, or you raise your hand, and you can turn on your audio. So let Dr. Bendich, there we go. I was going to say, there we go. So let's see. Do we have some questions? Marilyn, go ahead and unmute yourself.
Okay. Yes, I have a question. I was wondering, is it possible to have this destructive arthritis introduced into one's system through a bone paste, let's say from a cadaver that a surgeon would need to use in order to put you back together again? Or is it only through the wear and tear in your system?
Sorry, say that again. In what instance would you need a cadaver?
Okay, let's say if you broke your foot and the surgeon had to they literally had to rebuild your bones in your foot. So they use cadaver bone paste. So the DNA in someone that they take that from, can it be introduced into your system that can later cause problems with your bones or arthritis?
Yeah, interesting question. So I think if you had a surgery that required cadaveric bone or any sort of allograft in a part that's outside of your hip, it's unlikely that it would cause a hip arthritis. The only situation where you could potentially have a hip arthritis that's caused by a surgery in a distant site is if you had an infection that then migrated to your hip. If you did have an infection that migrated to your hip, that would destroy the cartilage, and that would lead to what we call a septic arthritis. But the alterations in the DNA that you were referencing, as far to my knowledge, would not cause a hip arthritis.
Thank you.
We have a question from Lorraine. How do you prevent a difference in leg lengths post-surgery?
That's an excellent question. So I, again, use computer navigation. So I know exactly how much I'm lengthening somebody before I leave the operating room. So I guess I'll separate it. So for my anterior hips, I use X-ray throughout the entire case to make sure that the components are positioned well. And based on kind of bony landmarks, I know exactly how much I'm lengthening somebody. For my posterior hips, where I'm using a form of computer navigation, I know exactly how much I'm lengthening them. And I also get an X-ray to confirm that. So when I leave the OR, I know exactly how much I've lengthened somebody. And that's all pre-planned based on pre-operative template. So my goal is usually to lengthen somebody by about 1 millimeter or 2. And the reason for that is not so that, and 1 millimeter or 2 is something that people tend to not detect. But if I can lengthen the limb a little bit, that provides additional stability to the hip and further minimizes the risk of dislocation.
Robert, did you have a question?
Yeah, I was just typing. What was it you called? What was the name of the condition where, as you exercise, it gets better rather than worse?
So that can be an inflammatory arthritis,
Okay.
like a rheumatoid or a psoriatic arthritis. There are other forms of inflammatory arthritides, but it's that category.
And could that possibly also be the bursa sac there that is creating that kind of situation that you would feel in the hip or the buttocks?
So yeah, so the bursal sac is kind of on the outside of your, what we call the greater trochanter.
Right.
And people tend to have a bursitis when you can push on that area. If it hurts you, then you probably have a bursitis there. That tends not to get better as you're more active. That tends to get worse if you're more active.
Okay. All right. Thank you.
Of course.
So we have another question. Stephen Waltman is how often do you get bleeding into the quad and trauma to the quad from the retractors?
Into the quad, almost, I can't think of an instance into the quad, but I do obviously retract. So it depends on the approach. Okay, so for posterior approach, we do spread the gluteus maximus muscle, and there's definitely some trauma involved in spreading that muscle, and we spread it at its raphe. Okay, and we also have to take down some tendons, which we then repair, but we are never near the quad. And going through the anterior approach, we go through the fascia of the TFL, which again is not the quad. It's on the outside. And most of the muscle that we are moving around, we don't actually cut any muscle. The muscle that we move around does get traumatized for sure. The retractors certainly traumatize it, but it's not the quad. It would be muscles nearby. I hope that answers it. So it'd be the abductor muscles, the TFL. Sometimes we do release the rectus, but rarely do we actually get any sort of bleeding into that. Does that answer your question?
Yeah, Stephen, he's on mute. So do we have any other questions this afternoon?
Very good talk. Thank you.
Yeah.
Thank you.
So
Yeah,
I
happy to
think,
answer any further questions,
So,
or
and-
if not, oh, go ahead.
no, I was just going to say these, Dr. Bendich has sent me the PowerPoint, and I can transfer that to a PDF and it will go to you in your email. This is also recorded so that we can share it with you, and it'll be on our website and you can look at it again if you want to review. And if you have any questions that you would like to share or ask Dr. Bendich later, you can email them to me and I can forward them and he could respond. So actually, we do have another question, and he wants, Jonathan Daner wants to know, would you present another seminar about the various procedures for the knee and arthritis, for knee arthritis and replacement?
Sure, I'd be happy to do it.
Okay, well, we'll work on that together and see when we can get you back. So, and yes, and Lorraine would love to have the PowerPoint. So we'll be sharing all of that with you. And thank you so much. It was very informational. And, you know, this is kind of the information in my mind anyway, that, you know, it takes some time to digest all of it. And then the questions come later. So please feel free to email me questions and I can forward them to the doctor and we can get those answered for you. And then I can also share everything. So any last questions? Doc, thank you so much, Dr.
Thank
Bendich.
you,
We
yeah.
will look
Of course.
forward to seeing you again for another program.
Sounds good. Thanks for letting me talk to you guys, and thanks for your attention.
Yes.
Thank you.
you.
Bye, everyone. Have a good afternoon.